Hey everyone, welcome to the first MRADS episode. I'm Eric Steinberg.
And I'm Mustafa Syed.
If you haven't already, please check out the intro video so you know what we are all about.
Let's get this party started.
Whoa. Alright, our first case is a 55-year-old male with a chief complaint of cough times 2 days. As we all know, the differential diagnosis is the meat of emergency medicine. And we love meat. So, right off the bat, how many differentials can you think of for cough?
I'm pretty sure I sat next to this dude on the subway. Thank God I'm in radiology.
Here's a quick differential, courtesy of Emra's Basics of Emergency Medicine. Let's go through it briefly. Obviously, our main concern with any patient with a cough is pneumonia, characterized by fever and sputum production. Your sinusitis patient will have rhinorrhea and sinus tenderness. That we treat with nasal spray, Sudafed, and antibiotics, especially if the symptoms are more than 7 days. We see foreign bodies in every possible orifice here in Manhattan, so always consider it, especially in your pediatric patient with a choking episode. Bronchoscopy is both the diagnostic and treatment modality of choice for foreign body. Asthma, or COPD, can present with cough as well. Although this may be more of a chronic issue, it's been shown that COPD exacerbations may benefit from a Z-Pack. How about that patient that walked 30 blocks and waited 3 hours for his or her upper respiratory infection? Send them home. Same thing for allergic rhinitis, but you can give them hospital-quality Benadryl. Don't forget about GERD, which is worse with lying down and relieved by the GI cocktail. And finally, ACE inhibitors are a fairly common cause of cough, and these patients should be followed up by their PMD and started on an angiotensin receptor blocker or some other hypertension med. So now that we went through all of the possibilities, let's finally take a look at some images.
The chest radiograph is the most common study you'll encounter in the ED. This is not a lecture dedicated to interpretation of the chest radiograph. We will go over the basic findings of pneumonia and some patterns you should look for. Here are the radiographic pearls for approaching pneumonia on a chest radiograph. These include the presence of the silhouette sign, bulging or retraction of the fissures, visibility of the diaphragms, or the presence of air bronchograms.
Where's the pneumonia in this one, man?
As the title says, this is as normal as a chest x-ray can be.
Go on.
On the PA view, this left view is a PA view, the lungs are clear. The costophrenic angles are sharp, and you can clearly see the border of the heart, the trachea, and the diaphragms. Moving on to the lateral, this can be a very confusing area, so keep the basics in mind. There are 3 spaces that should be clear: the retrosternal clear space, the clear space posterior to the heart, overlying the spine, and the retrotracheal triangle. Write this up here. These spaces will become important as we talk about the pathology. Remember that the lateral is used to figure out whether things are anterior or posterior, and the PA is used to figure out whether they're medial or lateral. This is a basic diagram pointing out some of the landmarks you'll be looking for. On the PA, you'll want to pay attention to the minor fissure, the border of the right diaphragm, the border of the right heart, the right paratracheal border, and on the left side, pay attention to the left heart border and the border of the left diaphragm.
I'm starting to sense a theme here, Moose. Pay attention to anatomical borders.
Right. Notice on the lateral, which part of the lung touches what? This is the basis of the silhouette sign. The upper lobe and middle lobes on the right and the upper lobe on the left are separated from the lower lobes by the major oblique fissure. The middle lobe is separated from the right upper lobe by the minor fissure. Notice that the heart contacts the left upper lobe, specifically the lingular portion, and the right middle lobe. Notice that the lower lobes make the most contact with the diaphragms. Also notice that there aren't many structures posterior to the heart. You have some lung, you have the aorta, you have the spine, and you have the esophagus. This is why this area should be clear. This is just to briefly show you the mediastinal divisions. Anterior mediastinum, middle mediastinum, containing the heart, the ascending aorta, the trachea and the hilum, and everything else in the posterior mediastinum. Now on to the exciting part.
Ooh, I see some schmutz on this x-ray.
You got it. Look at the PA. It's obvious there's an opacity in the left thorax. How do you know if it's anterior or posterior? Well, look at the left heart border. You can't see it anymore. This is called silhouetting. The reason you normally see the heart border is because the heart's soft tissue density interfaces sharply with air-filled lung, which is much less dense. If you put something of similar density next to the border, you won't see that border anymore. This should clue you into the fact that this is a left upper lobe pneumonia, specifically lingular. Look at the lateral. This becomes obvious. You see a wedge-shaped opacity overlying the heart, and it's got a slight bulge to it. This is because pneumonia is a space-occupying process. It pushes the fissure out.
Great. So we're using the PA to detect the missing heart border, and we're using the lateral to notice that this is an anterior process with a bulging major fissure. So it's got to be lingular.
Exactly. Let's move on. Use what we've learned so far. Here we have an opacity on the right. It's not really silhouetting anything, so that doesn't help as much. But look at the bottom of the opacity. Lung consolidations usually are not well defined unless something forces it to be. In this case, the minor fissure is outlining it. This means it is most likely the right upper lobe. Looking at the lateral, you see a nice outline of the minor fissure and the major fissure, and you can't see the retrotracheal space clearly because the opacity is projecting over it. So this is a right upper lobe pneumonia.
Again, this goes back to your 4 basic pearls. We don't see anything silhouetting here, but we do see bulging of the fissure on both the PA and lateral, which provide us with distinct anatomical landmarks. Again, we see badness on the superior portion of the lateral, so it must be right upper lobe. I don't know, at first glimpse, I don't see too much here, Moose. But I do see 3 arrows.
The positive arrow sign. Yeah, this is a little trickier. Can you spot the opacity? It's behind the heart. This is a common place to miss an opacity. Notice how the left heart border is preserved. This is a clue that, unlike the previous example, this is not an upper lobe opacity. You also lose the left diaphragm border because it's silhouetted. If you look on the lateral, you see opacification of the area we said should always be clear. This is what we call a positive spine sign. You see this area right here, this wedge shape and opacified, and now you know this is a left lower lobe pneumonia.
Well, I still think this could be easily missed, but as long as we continue with the same approach, we won't miss it. Simply put, the diaphragm silhouettes out, and the heart doesn't. It shouldn't be anything other than left lower lobe pneumonia. The lateral again helps us, showing badness around the spine.
The opacity is pretty obvious here. Right lung. But what lobe? You don't see a nice sharp border, but what you do see is a loss of a right heart border, with preservation of the right diaphragm border. Look at the lateral. You see a nicely outlined, wedge-shaped opacity, which is contained by the right major fissure. This is a classic right middle lobe pneumonia.
Now, not to beat a dead horse here, but the same rules apply. Sweet, let's keep on moving. So let's take what we have learned so far and localize this pneumonia. Where's the badness, everybody?
Again, there is a hazy opacity right here in the lower right lung. It could be right upper lobe, it could be right middle lobe. But go back to the basics. Do you see a fissure? No, so that doesn't help as much. Do you see a silhouette sign? Yes. The right diaphragm border is lost. Additionally, the right heart border is preserved. Look at the lateral to clinch your diagnosis. Here you have a positive spine sign. This is a right lower lobe pneumonia. Last but not least, we often hear the term air bronchogram. This is a form of silhouette sign, if you will. Normally, bronchi are barely visible because they are air-filled structures surrounded by air-filled tissue. When you have consolidation, all the lung tissue, the alveoli, opacifies. This colors in the lungs. Since the bronchi remain air-filled, you have this opacified tissue outlining these air-filled tubes. And this is called an air bronchogram. You see the circular oblong lucencies in the opacity? These are the air bronchograms.
Did you just say oblong? Really? Oblong? Such a radiology word. Oblong.
Now remember, just because there is an opacity doesn't mean it's pneumonia. This is where clinical history and clinical intuition make all the difference. Say someone took a hit to the left side of their chest. That area could be opacified, but it would be due to blood or due to contusion, like parenchymal bleeding. A very large cancer or an airway obstruction can opacify a portion of the lung as well.
Lung collapse, like intubating a single mainstem bronchus, something us ER residents never do, can opacify only one side. Also, edema, both cardiogenic and non-cardiogenic, can result in opacification, although, as we know, these are usually bilateral.
So quick pointers. On the lateral view, if you see a wedge-shaped opacity over the heart, it's going to be a lingular or right middle lobe opacity. If you see loss of the clear space overlying the spine, it's a lower lobe opacity. Diaphragms don't always have to silhouette in lower lobe opacities. This is because some portions of the lower lobe don't touch the diaphragm. The lateral will help you. If your costophrenic angles are not sharp, you have an effusion on your hands.
Wow, that sure makes reading a pneumonia chest x-ray much, much easier. But we all know that all pneumonias are not treated equally. An important question that always comes up is, what counts for healthcare-associated pneumonia? So let's hit this topic. When we use the term HCAP, or healthcare-associated pneumonia, our real concern is identifying the people who are at high risk for multi-drug resistant pneumonia. These are your patients who are hospitalized for more than 2 days within the past 90 days, patients with known antibiotic resistance, your patients who have a family member with a known multi-drug resistant pathogen, your nursing home residents, your patients who are on home infusion therapy, patients with immunosuppressive disease, and of course, the very common hemodialysis patient.
And patients who don't wash their hands.
That's everyone. So you want to keep these people in mind when choosing what antibiotics to use. And here are the EMERA Antibiotics Guide recommendations for the treatment of pneumonia. For bread and butter community-acquired pneumonia in a healthy patient, that means no comorbidities, prescribe your patient a Z-Pak, Biaxin, or Doxy. For those with comorbidities, outpatient management should be treated with a respiratory fluoroquinolone, such as levofloxacin or moxifloxacin. And for inpatient treatment of community-acquired pneumonia, ceftriaxone and azithromycin are your go-to antibiotics. For healthcare-associated pneumonia / multi-drug-resistant pneumonia, not 1, not 2, but 3 drugs are recommended. Cefepime or Zosyn for gram-positive, gram-negative, and Pseudomonas coverage, a fluoroquinolone for additional Pseudomonas coverage, and vancomycin for your MRSA coverage. Now, the awesome ER physician is 2 great things. Other than being ridiculously good-looking,
Okay.
he or she is an excellent diagnostician and a keen risk stratifier. Evidence-based clinical decision rules such as PORT, PSI, and CURB are excellent tools to predict potential mortality and disposition for your patients who you have diagnosed with pneumonia. Now, I personally use CURB because it's shorter, it's based on common sense, and the results were quite impressive. An answer of yes to any of their questions counts as 1 point. So when asking all the questions, 0 or 1 point predicted 0.6 and 2.7% 30-day mortality respectively, which is defined as low risk. Simply put, 0 or 1 point, low risk, and you can consider these patients for outpatient management. 2 points is borderline outpatient or inpatient management, as these patients had up to a 7% 30-day mortality. I'll tell you right off the bat, I'm admitting 100% of those. 3 points is considered severe, as these patients have a 14% 30-day mortality. You're admitting all of those. 4 to 5 points is the highest risk group with a 28% 30-day mortality. For these patients, you may want to consider calling the ICU. Now, if you have easy access to different databases such as MDCalc or MedCalc, by all means, feel free to also use the port to guide your management. But if you're going to take one thing home, this is my opinion. Both of these rules ask 4 basic questions. 1. Is your patient old? According to port, just being 75 alone, without any complaints, already predicts up to a 3% 30-day mortality. Number 2. Do they have comorbidities, such as diabetes? 3. Any abnormal vital signs? I don't care what they are any of them abnormal? 4. Any abnormal labs? Now, if you combine these 2 studies, if you answer yes to any of these 2 questions, the mortality risk is high enough to reflexively admit the patient. So again, old, comorbidities, concerning vitals, concerning labs.
Solid thought process. I just thought you guys admitted anyone over the age of 40.
Next. All right, I think that was a pretty awesome review of pneumonia. Now on to our second case of the month. 19-year-old female with right lower quadrant abdominal pain times 12 hours.
And another creepy poster. Where do you get these?
That doesn't matter. It may be creepy, but it sends an important message. Don't gamble with appendicitis or use a laxative. But what we really shouldn't do is make the gamble that all right lower quadrant pain is appendicitis, especially in those people with the female parts. Let's go through the differential of lower abdominal pain. Here's a quick look at some common causes of lower abdominal pain from EMRA's Basics of Emergency Medicine. As you can see, there is a ton of pathology that can cause lower abdominal pain. As always, the key is to weed out the serious stuff and then move on to the common. API is the obvious concern for anyone with right lower quadrant pain. Other things to look for are presence of fever, nausea, vomiting, and McBurney's tenderness. Something that should be absent is hunger. To me, a positive cheeseburger at the bedside has pretty good negative predictive value for appendicitis.
As does the positive cigarette break or the positive sunglasses sign, right?
Exactly, man. Back to appendicitis. CT with PO and IV contrast remains a study of choice. Ultrasound may be obtained first, especially in the PEDS population, to avoid radiation. Hernia should always be a concern for these patients as well. Always, always, always pull down those pants and take a look at the inguinal region. It would be pretty embarrassing to miss a tennis ball-sized strangulated hernia. And of course, your patient would conveniently forget to tell you that it's there. Diverticulitis usually presents with left lower quadrant pain, but it is definitely possible to have in the right lower quadrant as well. There's a classic board question regarding the Japanese population and cecal diverticulitis. Ectopic pregnancy is a must. Get that UPreg right away. If positive, throw an ultrasound on immediately. This should be the first thing you think of with any female with abdominal pain and syncope. Torsion, whether ovarian or testicular, is a time-sensitive emergency.
Time is testicle.
You got it. Look for sudden onset pain, and I mean sudden onset, and get an official ultrasound ASAP. Now those are the very, very serious causes of right lower quadrant abdominal pain. Let's move on to the more common stuff. Ovarian cysts can be quite painful and are sometimes hard to differentiate from a torsion. Now unless they are massive and ruptured, these patients can follow up with their OBGYN. PID, pelvic inflammatory disease, is all too common and is present in our sexually active pains with vaginal discharge and CMT, cervical motion tenderness. This is usually a clinical diagnosis, which isn't all that great because we are terrible, and I mean terrible, at identifying vaginal discharge. Fishy, frothy, curdy, who the hell knows? Just treat them and send them home. Now, the exception to this rule is if you think there's a TOA, a tubo-ovarian abscess, or if you don't think the patient will take her meds at home. In these cases, you may want to consider admission. Then there's Mittelschmerz. What an awesome word. I'm going to say it again. Mittelschmerz. Again, a diagnosis of exclusion and a patient with mid-cycle pain. UTI can definitely cause lower abdominal pain. Always dip the urine while getting the UPreg and check for that CVA tenderness. Make sure your patient does not have pyelonephritis. Constipation. The very young, the very old, and the very opioid dependent. Encourage a high fiber diet, maybe some osmotic agents, an enema or two, or one of your intern's fingers can do the trick. Finally, a kidney stone or aortic pathology can cause abdominal pain anywhere, so always keep those two in the back of your mind. Always. Now, some rarer things that may pop up in your career and more commonly on your exams is epiploic appendicitis and Yersinia infection. Two things that can cause your pseudoappendicitis. Now, I know that was a lot, but eventually this should be automatic. So now that we have our dozen or so differentials in our head, let's go to the scan.
Too much gyne, man. Once again, women making things complicated.
Amen.
For a vestigial structure, the appendix sure causes everyone a lot of problems. The biggest one being finding it. And no, you don't have to do 5 years of general surgery to get good at identifying it. Besides, why would anyone want to do 5 years of general surgery?
Beats the hell out of me, dude.
So how do you find it? For the sake of everyone, the best thing is getting an optimal study. You need luminal, oral, and intravenous contrast. Whether you administer it rectally or orally is up to you, but both contrasts help a lot. Practice makes perfect. You should get in the habit of tracing a large bowel. The best way to approach it is by putting your pointer on the area of interest and following it while scrolling. Some people trace from the rectosigmoid up, some people like to find the cecum first. Whatever, just trace it. The key to finding the appendix is finding where the ileum terminates into the cecum. At this junction, there is a mushy, fatty, soft tissue density, which we all know as the ileocecal valve. This is where the contrast can help you, because you can see where the contrast is going in from the ileum into the cecum. The appendix is always located on the same side of the ileocecal valve, somewhere between the cecal apex, remember the cecum ends as a blind pouch, and the terminal ileum. 2/3 of appendices are retrocecal, and 1/3 are inferomedial.
Wow, 2/3 of appendices are retrocecal? What physical examination should we all make sure we're doing then? You got it, the psoas sign, which is pain elicited with passive right hip extension.
So let's say you found it. Congratulations. Now you need to determine if it's normal or abnormal. The basic checklist for this is the appendix dilated? It should be less than 6 millimeters in diameter. Measure it every single time. It can have air. It can almost be flat. It may or may not fill with contrast. These are normal variants. However, it should not have fluid in it. The fat around the appendix should be clean and homogeneous, which means no variation in color. It should be significantly darker than the soft tissue because fat is much less dense. The borders of the appendix should be sharp. The walls should be a thin line. There should be a nice interface with the fat. Well-defined tissue interfaces are an important pattern to recognize in radiology.
Okay, so if I had an appendix, I want my appendix to be less than 6 millimeters, I want no fluid in it, and I want no surrounding badness. I can handle that.
I'm going to start by scrolling through some images I got for a normal appendix. This is a good example. I want you to try to find the points that we talked about before, identify some of the anatomy, and then we'll go through it again. So we're scrolling from the top down. Did you see it? Let's go through this. So let's identify some normal anatomy. This is your psoas muscle. This is your ascending colon. Now we're going downwards into the pelvis, and as you go down, you see some oral contrast right here. This is the terminal ileum. It's attaching into the colon, specifically the cecum, and you can see the contrast cross over from the ileum into the colon. And here you have a soft tissue, mushy density. This is what we talked about, the ileocecal valve. Try to identify this, and with practice you'll be able to get it on every CT. Now as you continue down, again you can see the contrast in the ileum and the colon, and you can identify the ileocecal valve. And if you come down further, what you'll see is the appendix come off the same side. Right here, see this little bubble, follow it. And as you can see, it's air-filled and flattened towards the end. But right there, that's your appendix. In this case, it was a little more subtle, but sometimes it can be pretty tough to find. Just practice, and you'll find it every time.
Practice? You talking about practice?
Here I have another example. The ileocecal valve is not included in this picture, but here you'll see an appendix. And there it is. It's very well defined, the walls are thin, it's tubular, it's full of air, and the fat around it is not inflamed. And the point I want to make here is that it stays behind the cecum the entire time. So if you look right here, this is the cecum, this is where the appendix just inserted into it, and if you follow it out, this is a non-thickened, air-filled structure, and it kind of terminates right behind the cecum. This is a retrocecal appendix. This example is to show you what mesenteric stranding is, or inflammatory changes within the fat. There are other findings here, but we'll go over them in the upcoming slides. What I want you to look at is the right image. Now I want you to look at the colon wall, and I want you to look at the fat around it. Look how different the densities are. The fat around the colon wall is almost black. Now if you look at the left image, you can hardly define the colon wall. And if you look at the fat, it's gray, it's hazy, there's some lines in it. This is inflammatory change. This is a result of edema and high blood flow because of inflammation. So this is one of the signs you should be looking for. So what causes appendicitis? Who knows? Who cares? Well, that's not entirely true, but a lot of times it's just a finding. Sometimes you can see a cause. In this case, the appendix, right here, inserts into the cecum, again, it's flattened, and then you come across this round calcified density, and then immediately following that, it's dilated, it's fluid-filled, you can tell because of this low density, and the walls are fuzzier, they're not thin, and they're not interfacing sharply with the fat. So in this case, this is appendicitis secondary to obstruction from a fecalith, and this round calcified object, this is the fecalith. This is your run-of-the-mill appendicitis. What I want to emphasize in this image is the difference with and without intravenous contrast. It is much easier to find the appendix with intravenous contrast. Here we have a few findings. You have this dilated tubular structure, which is full of fluid. This low-density material, where air should be, is fluid in this appendix. Again, the wall is thickened. And if you look around it, the wall is bright. And this brightness is what we call enhancing. So the rim is enhancing because the appendix is inflamed, and because of that inflammation, there's hyperemia. And that increased hyperemia manifests as this enhancement. If you look around it, the bowels should just be soft tissue seated in mesentery, which is fat. But here, you can't really see the fat. The fat is grayed out, and additionally, you see gray stuff right here beneath. And that represents free fluid in the pelvis. This is a much less dramatic case of appendicitis, but it is appendicitis. The appendix is dilated, and it is a little bit fluid-filled, and the walls are thickened, and they don't interface well with the fat. However, there isn't a whole lot of mesenteric inflammation. You can see the gray in the fat still. So this is an example of early appendicitis. This is a much more dramatic presentation. Here the appendix is much more difficult to outline, and for good reason. You could probably find the origin if you scrolled on this image. But what you see here is a collection of stuff. Right here, and right here. Again, it has the enhancing walls that we talked about before, and additionally, it's stretching out across the fat over into the psoas muscle. This is a 2-for-1. This person had appendicitis, it perforated, that's probably why you can't see the appendix, and now you're seeing this collection of stuff with enhancing walls and septations, this low fluid density and these bright densities around representing the enhancement. This is probably an abscess, and this abscess spread over into the psoas muscle. And you can see the psoas looks just like the appendix here. And over here you can look at the normal psoas to kind of compare the difference. And this brings up an important point. Here we have an appendix which is fluid-filled, thick, with a fuzzy wall and fat stranding. What else do you see? The bladder. Notice the asymmetric thickening of the bladder wall on the left. Don't mistake this for cystitis. That could be possible, but in this case it's much more likely that the adjacent inflammatory changes in the appendix are causing the bladder wall to be thickened. So some quick pointers. Abnormal appendix. A dilated, fluid-filled appendix measuring greater than 6 millimeters without the presence of oral contrast in it. The loss of a sharp margin with fat with enhancing thickened walls. Mesenteric stranding, or fatty inflammation. Presence of a fecalith, that round calcified object we saw earlier. Free fluid within the pelvis, which may indicate a ruptured appendix. Surrounding septated, enhancing collection, which would indicate an abscess, or inflammation of adjacent organs. Remember to always look for free air. Oral and intravenous contrast should always be present. Save yourselves the guesswork. So, as Eric so eloquently touched on before,
Thank you.
the differential for right lower quadrant abdominal pain is large, but common things happen commonly. Check for stones and pyelonephritis, diverticulitis, and epiploic appendigitis. Inflammatory bowel disease, like Crohn's, can present with similar pain because of the proximity of the terminal ileum to the appendix. And of course, the entire gynecology spectrum of pathology. Thanks, ladies!
Ha! Well, that was great. Thanks, Moose. You know, after a few of these videos, I don't think I'll ever need to consult a radiologist ever again.
Yeah, right. We'll see about that.
Alright, well, I know that we're pretty quick to scan our right lower quadrant pain patients, especially if they are tender. But, again, there is a helpful, validated clinical decision rule we can use called the Alvarado score. Again, this is especially important if we're trying to avoid radiation in a constipated child. As you can see, it takes into account signs, such as right lower quadrant or rebound tenderness, symptoms, such as migration of pain or anorexia, and lab values, such as white count and shift. Studies ruling out appendicitis using an Alvarado of less than 3 or 4 points have a sensitivity of 96%, which is pretty good. Studies ruling in appendicitis using an Alvarado score of greater than 6 or 7 have a specificity of 58 to 88%, depending on the study and the score cutoffs used. That's not so good. A large study in 2007 by McKay and the American Journal of Emergency Medicine recommends CAT scan for an Alvarado of greater than 4, surgical consultation immediately for an Alvarado greater than 7, and no CAT scan for an Alvarado score less than 3, as appendicitis is unlikely. As far as antibiotics go, the EMRA Antibiotics Guide recommends cefoxitin or cefotetan for simple appendicitis. Note that ciproflagyl, which we commonly use, is not included in their recommendations. For complicated appendicitis, which is gangrenous, perforated, abscess, phlegmon, or immunocompromised patients, the big guns are recommended. Now let's quickly review the main topics we went over today. For pneumonia, most important thing, look at those borders.
Borders.
The heart, the diaphragm, and the fissures, the anatomical borders will help you localize where the badness is occurring. It's important to know what counts as healthcare-associated pneumonia. Why? Because we're treating multi-drug resistant pathogens. Not 1, not 2, but 3 antibiotics are recommended for treatment of this patient population. The PSI score, the CURB score, they provide us with evidence-based mortality risks to help us make the right disposition for our patients. As far as appendicitis goes, the first thing you got to do is find the damn thing. And as Mustafa eloquently put,
Yes.
we can look for the ileocecal valve and we can trace the colon. After we found it, we have to know what the badness is. Is it big? Greater than 6 millimeters? Is it wet? Is it fluid-filled? Is it unshapely with ugly fat, non-homogeneous fat, or bad borders? And finally, another evidence-based clinical decision rule we can use is the Alvarado score. And as we touched upon before, it has great negative predictive value, good for ruling out the appendicitis in certain patients that we can maybe avoid CAT scanning. It's the wild card.
It's never that exciting. 54-year-old male with a recent dental extraction is now complaining of fever and neck pain and swelling. Here are his images.
What could it be? What is the diagnosis? Well, the good news is you've got a month to figure it out.
The bad news is you probably won't figure it out.
Ha ha ha.
Thank you for listening to us. We hope it wasn't too painful.
Now, this was our first video, and we hope to make many, many more. So please, please, please leave us your feedback. Shoot us an email at emradsnyc, that's EMRADS NYC, at any time, and we'll try to get back to you.
Stay tuned for next month when we go over wrist films and stroke.
Wrist films and stroke. Interesting. I wonder how those two could be related.
Who knows, honestly.
And we reveal the answer to the first wild card. Thanks again for listening, guys.
Thanks for listening, guys.